Hello students. Today we'll be studying about parietal lobe functions and syndromes. After studying this module, you shall be able to learn about location and functions of parietal lobe, learn about the damage to parietal lobe and related syndromes, learn about the diagnosis of parietal lobe syndromes, learn about contralateral neglect syndrome, learn about parietal lobe epilepsy. Introduction. Each cerebral hemisphere is divided into 4 lobes by sulci and gyri. The sulci or fissures are the grooves and the gyri are the bumps that can be seen on the surface of the brain. The folding created by the sulci and gyri increases the amount of cerebral cortex that can be fit into the skull. The parietal lobe is named for the parietal bone that is directly over that region as part of the skull. The parietal lobe is one of the 4 major lobes of the cerebral cortex in the brain of every mammal. Parietal lobe, the wall, is located on the side of the cerebral hemisphere just above the occipital lobe, behind the central sulcus and the caudal to the frontal lobe. Its main function is to process and integrate somatosensory and visual information. It processes sensory information that has to do with taste, temperature, and touch. This lobe interprets sensory information like awareness of body parts and aiding in physical navigation. For example, your parietal lobe automatically tells you where your tongue is as you chew to keep you from biting it. The parietal lobe is divided into 2 regions based on the functions. One involves sensation and perception, and the other is concerned with integrating sensory input, primarily with the visual system. The first function integrates sensory information to form a single perception, that is, cognition. The second function constructs a spatial coordinate system to represent the world around us. It has been generally accepted that the inferior parietal lobe is the primary cortical region, but not the only region governing attention. The inferior parietal lobule, that is IPL, is located in the posterior aspect of the parietal lobe adjacent to the occipital lobe. It receives inputs from visual and somatosensory cortices and in an area important for the integration of these 2 modalities. Parietal lobe is also associated with the sensation of kinesthesia, that is, the perception of warmth and cold and of vibration. It is also involved in writing and in some aspects of reading. It further plays an important role in integrating sensory information from various senses and in manipulation of objects. Certain portions of the parietal lobe are involved with visuospatial processing. The angular gyrus is involved in the recognition of visual symbols. Further, this lobe is divided into 2 hemispheres, the left and right. The left hemisphere is involved in symbolic functions in language and mathematics. Meanwhile, the right hemisphere is specialized in carrying out images and the understanding of maps, that is, spatial relationships in a 3-dimensional world. Some portions of the parietal lobe are also important in language processing. The presensory, secondary sensory or secondary sensory association areas are located behind the post-central gyrus in the parietal lobe. These areas are capable of detailed discrimination and analysis. Information is first processed in the primary sensory area and is then sent to the secondary sensory areas. This region also receives sensory feedback from joints and tendons in the body and is organized in the same manner as the motor strip. It integrates sensory information from different modalities, particularly specializes in determining spatial sense and navigation. Its regions are enabled to map objects perceived visually into body coordinate positions. Its function also include processing information relating to the sense of touch. The posterior parietal cortex is often referred to as the dorsal stream of vision. This dorsal stream has been called both the where stream, as in the spatial vision, and the how stream, as in vision for action. The posterior parietal cortex, that is PPC, receives somatosensory and or visual input, which then through motor signals controls movement of the arm, hand as well as the eye movements. Various studies found that different regions of the posterior parietal cortex represent different parts of space. The lateral intraparietal or the LIP contains a map of neurons representing spatial locations and provide attention to these locations. It is used by the oculomotor system for targeting eye movements when appropriate. The ventral intraparietal or VIP area receives input from a number of senses like visual, somatosensory, auditory and vestibular. The medial intraparietal or the MIP area, neurons encode the location of the nose-centered coordinates. The anterior intraparietal or the AIP area contains neurons responsive to shape, size and orientation of objects to be grasped as well as for manipulation of hands. The AIP has neurons that are responsible for grasping and manipulating objects through motor and visual inputs. Studies have shown that humans have similar functional regions in and around the intraparietal sulcus and parietal occipital junction. The human parietal eye fields and parietal reach region appear to be organized in gaze center coordinates so that their goal-related activity is remapped when the eyes move. Both the left and right parietal systems play a determining role in self-transcendence, the personality trait measuring predisposition to spirituality. Damage to the parietal lobe may result in disorders that are dominant in speech and language, such as anomia, alexia with agraphia, left-right disorientation, finger agnosia, and acalculia. Brodmann areas in the parietal lobe have been delineated to describe features of somatosensory processes. Areas 3, 2 and 1 are the post-central gyrus located on the primary sensory strip, with area 3 being above the other two. These are somatoesthetic areas, meaning that they are the primary sensory areas for touch and proprioception, including kinesthesia. Area 5-7, that is superior parietal lobule, and 40, that is supramarginal gyrus, are found posterior to the primary sensory strip and are considered presensory association areas where somatosensory processing occurs. Area 39 is the angular gyrus. Parietal lobe function and dysfunction. Cortical functions of the parietal lobe are two-point discrimination through touch alone without other sensory input like visual, graphesthesia, recognizing writing on skin by touch alone, touch localization, that is bilateral simultaneous stimulation. The parietal lobe plays important roles in integrating sensory information from various parts of the body, knowledge of numbers and their relations, and in manipulation of objects. Its function also includes processing information relating to the sense of touch. Portions of the parietal lobe are involved with visuospatial processing. Although multisensory in nature, the posterior parietal cortex is often referred to by vision scientists as the dorsal stream of vision, as opposed to the ventral stream in temporal lobe. This dorsal stream has been called both the where stream, as in the spatial vision, and the how stream, as in the vision for action. The posterior parietal cortex, that is PPC, receives somatosensory and or visual input, which then, through motor signals, controls the movement of the arm, hand, as well as the eye movements. Various studies in the 1990s found that different regions of the posterior parietal cortex in macaques represent different parts of space. The lateral intraparietal, that is LIP area, contains a map of neurons, retinotopically coded when the eyes are fixed, representing the saliency of spatial locations and attention to these spatial locations. It can be used by the oculomotor system for targeting eye movements when appropriate. The ventral intraparietal, that is the VIP area, receives input from a number of senses like visual, somatosensory, auditory, and vestibular. Neurons with tactile receptive fields represent space in a head-centered reference frame. These cells with visual receptive fields also fire with head-centered reference frames, but possibly also with eye-centered coordinates. The medial intraparietal or the MIP area, neurons encode the location of a reach target in nose-centered coordinates. The anterior intraparietal or the AIP area contains neurons responsive to shape, size, and orientation of objects to be grasped, as well as for manipulation of hands themselves, both to be viewed and remembered stimuli. The AIP has neurons that are responsible for grasping and manipulating objects through motor and visual inputs. The AIP and ventral premotor working together are responsible for visuomotor transformations for actions of the hand. More recent fMRI studies have shown that humans have similar functional regions in and around the intraparietal sulcus and parietal occipital junction. The human parietal eye fields and parietal reach region, equivalent to LIP and MIP in the monkey, also appear to be organized in gaze-centered coordinates so that their goal-related activity is remapped when the eyes move. Both the left and the right parietal systems play a determining role in self-transcendence, the personality trait measuring predisposition to spirituality. Damage to the right hemisphere of this lobe results in the loss of imagery, visualization of spatial relationships, and neglect of left side space and left side of the body. Even drawings may be neglected on the left side. Damage to the left hemisphere of this lobe will result in problems in mathematics, long reading, writing, and understanding symbols. The parietal association cortex enables individuals to read, write, and solve mathematical problems. The sensory inputs from the right side of the body go to the left side of the brain and vice versa. The syndrome of hemispatial neglect is usually associated with large deficits of attention of the non-dominant hemisphere. Optic ataxia is associated with difficulties reaching toward objects in the visual field opposite to the side of the parietal damage. Some aspects of optical ataxia have been explained in terms of the functional organization described above. Apraxia is a disorder of motor control which can be referred neither to elemental motor deficits nor to general cognitive impairment. The concept of apraxia was shaped by Hugo Lippmann about 100 years ago. Apraxia is a predominantly symptom of left brain damage, but some symptoms of apraxia can also occur after right brain damage. Amorphosynthesis is a loss of perception on one side of the body caused by a lesion in the parietal lobe. Usually, left-sided lesions cause agnosia, that is, a full body loss of perception, while the right-sided lesions cause lack of recognition of the person's left side and extrapersonal space. The term amorphosynthesis was coined by D. Denny Brown to describe patients he studied in the 1950s. Can also result in sensory impairment where one of the affected person's senses like sight, hearing, smell, touch, taste and spatial awareness is no longer normal. Several studies have suggested that abnormal parietal function may be associated with schizophrenia. There is a possibility that gray matter abnormalities begin in parietal and occipital lobes, progress towards the frontal regions, causing schizophrenia, structural and functional alterations. Damage to parietal lobe and diagnosis. Individuals with damage to the parietal lobes often show striking deficits such as abnormalities in body image and spatial relations. Damage to the frontal part of the parietal lobe on the left side leads to the following deficits. Adversely affects verbal memory and the ability to recall strings of digits, impairs sensation on the opposite side of the body, creates difficulty in identifying a sensation's location and type like pain, heat, cold or vibration, creates difficulty recognizing objects by touch or by their texture and shape. Damage to the left parietal lobe can result in what is called Justman's syndrome. It includes right-left confusion, difficulty in writing, that is agraphia, difficulty in mathematics, that is acalculia, disorders of language, that is aphasia, and the inability to perceive objects normally, that is agnosia. Bilateral damage, that is large lesions to both sides of the parietal lobes, can cause Bellin syndrome, a visual attention and motor syndrome. This is characterized by the following features: inability to voluntarily control the gaze, that is ocular apraxia, inability to integrate components of a visual scene, that is simultaneoxia, inability to accurately reach for an object with visual guidance, that is optic ataxia. Spatial deficits, primarily to memory and personality, can occur if there is damage to the area between the parietal and temporal lobes. Some common tests for parietal lobe functions are Kimura box test for apraxia and 2-point discrimination test, that is somatosensory, Seguin-Goddard form for tactile form recognition, line bisection for contralateral neglect, right-left differentiation for spatial relations. Contralateral neglect syndrome. In 1941, the British neurologist W.R. Brain reported 3 patients with unilateral parietal lobe lesions in whom the primary problem was varying degrees of perceptual difficulty. Brain described their peculiar deficiency in the following way. Though not suffering from a loss of topographical memory or an inability to describe familiar routes, they nevertheless got lost in going from one room to another in their own homes, always making the same error of choosing a right turning instead of a left, or a door on the right instead of the one on the left. In each case, there was a massive lesion in the right parieto-occipital region, and it is suggested that this resulted in an inattention to or neglect of the left half of external space. The patient, who is thus cut off from the sensations which are necessary for the construction of a body scheme, may react to the situation in several different ways. He may remember that the limbs on his left side are still there, or he may periodically forget them until reminded of their presence. He may have an illusion of their absence, that is, they may feel absent although he knows that they are there. He may believe that they are absent but allow himself to be convinced by evidence to the contrary. Or finally, his belief in their absence may be unamenable to reason and evidence to the contrary, and so constitute a delusion. W. R. Brain in 1941. This indicates the link between parietal lobe lesions and deficits in attention or perceptual awareness. Based on a large number of patients studied since Brain's pioneering work, these deficits are now referred to as contralateral neglect syndrome. It includes the following symptoms: inability to perceive and attend to objects or even one's own body in a part of space, despite the fact that visual acuity, somatic sensation, and motor ability remain intact. Failure to report, respond to, or even orient to stimuli presented to the side of the body or visual space opposite to the lesion. Difficulty in performing complex motor tasks on the neglected side, including dressing themselves, reaching for objects, writing, drawing, and to a lesser extent orienting to sounds. Description of the above image. Characteristic performance on visual spatial tasks by individuals suffering from contralateral neglect syndrome. In A, the patient was asked to draw a house by copying the figure on the left. On the right is the subject's imitation. In B, the patient was asked to bisect the line. C, sequential self-portraits made by the artist Anton Riedesheet over the period of his recovery from a right parietal stroke, showing progressive improvement in his attention to the left side of his mirror image. Parietal lobe epilepsy. Parietal lobe epilepsy is a relatively rare form of epilepsy, comprising about 5% of all epilepsy. In this, seizures arise from the parietal lobe of the brain. Parietal lobe epilepsy can start at any age and occurs in both males and females equally. Since the parietal lobe involves the processing and integration of sensory and visual perception, seizures originating from the parietal lobe can involve both sensory and visual sensations. There are different types of parietal lobe seizures. Symptoms. Somatosensory seizures are the most common type of seizures in parietal epilepsies. Patients with these types of seizures describe feeling physical sensations of numbness and tingling, heat, pressure, struck by electricity, and or pain. Pain, though a rare symptom in seizures overall, is quite common in parietal seizures, occurring in up to 1/4 of patients. Some patients describe a typical Jacksonian march, in which the sensation marches in a predictable pattern from the face to the hand, up the arm and down the leg. They may have somatic illusions where they experience a feeling like their posture is distorted and that their arms or legs are in a weird position, or are in motion when they are not, or that a part of their body is missing or feels like it does not belong. Treatment with anti-epileptic medication is usually effective in controlling seizures in parietal lobe epilepsy. In severe cases, surgery may be an option. Summary. Parietal lobe is located on the side of the cerebral hemisphere just above the occipital lobe behind the central sulcus. Its main function is to process and integrate somatosensory and visual information. It processes sensory information that has to do with taste, temperature, kinesthesia and touch. Damage to the parietal lobe may result in disorders that are dominant in speech and language, such as anomia, alexia with agraphia, left-right disorientation, finger agnosia, and acalculia. Bilateral damage to the parietal lobes can cause balance syndrome. Massive lesion in the right parieto-occipital region causes the contralateral neglect syndrome. Parietal lobe epilepsy seizures arise from the parietal lobe of the brain. Parietal lobe epilepsy can start at any age and occurs in both males and females equally. Some patients describe a typical Jacksonian march in this context. Thank you.